mortality gap essentially refers to the difference in anticipated lifespan between those with and those without mental health concerns. And the literature would suggest that that's anywhere between 7 and 30 years. We talk a lot about exercise as medicine. Like medicine, it only works if you take it.
Yeah.
And so it's one thing to get someone started, but it's another thing entirely to keep them going.
Things like exercise and sport as a way to implement in these countries where the resources aren't there, the stigma of traditional therapies and treatments is still there, I think is huge benefit. And it's so fantastic to see that being done.
One of the quotes that a participant came back with, and I'll literally never forget this, they said, "You want us to get up every day and go for a run. I can barely get out of bed." So low motivation is a real issue.
And I think this whole notion really ties into what you alluded to earlier about exercise as medicine being a little problematic, because I know when I think of medicine, I think of, oh, well, I have to take it, it's going to taste disgusting, yes, or you just do it for function.
And you have to have a specific dose, and you have to do it at a particular time.
Yes, you don't get to choose and have a fun medicine. Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment. Hello everybody and welcome back to the show. Today we are joined by Dr. Rob Stanton to discuss the physical healthcare of people with mental illnesses. Rob is an associate professor at Central Queensland University here in Australia, who lectures in clinical exercise science. Rob is also an experienced accredited exercise physiologist who completed his PhD in the use of exercise in inpatient mental health settings. So he brings a wealth of clinical experience and research background in this area to our discussion today. In today's discussion, we cover why people with mental illnesses are dying decades earlier than the general population, how healthcare professionals, including GPs or physicians, psychologists, and accredited exercise physiologists, can better help the health of people with mental illnesses, why exercising can be more difficult if you're facing a mental illness, and much, much more. If today's episode of the Mental Wellbeing College brings value to your life, we would be so grateful if you were to hit subscribe or follow, as this is how we continue to grow the show. Our mission here is to communicate evidence-based science in a digestible way to people the world over, particularly those dealing with mental health challenges themselves or those treating mental health challenges in others, such as psychologists, GPs, exercise physiologists, etc. And you subscribing and or following really helps us to spread the word and help us hit that mission. Thanks so much for tuning in. Hope today's episode with Rob brings value to your life, and now over to the discussion. All right, Dr. Rob Stanton, welcome to the Mental Wellbeing College.
Andy, thanks very much for inviting me on. It's a great pleasure to be here.
Yeah, it's absolutely fantastic to have you on. I'm going to be talking about a very important topic, the physical health and physical health care of people with mental illnesses. A really important topic and one that's really surprising for me. We were just chatting just then actually, and I reflected that this is not something that I was aware of even in my own postgrad training in psych. So to be able to dive in and explore it with you, I think is really going to open a lot of eyes in a really important way.
Yeah, I hope so. It's a under-recognised issue in the mental health space and particularly by the general population as well.
Yeah, and one of those, I think, under-recognised issues is this notion of the mortality gap, which I only came across very recently. Can you elucidate as to what that is, particularly with reference to people with mental illnesses, Rob?
Sure. So the mortality gap refers to essentially the difference in anticipated lifespan of someone who experiences or lives with mental health concerns. And you'll hear different language being used, and I'll use different language in this talk, I'm sure, as to whether we call these people, individuals who experience mental health concerns, those with lived experience, mental health consumers. We're really all talking about the same group, people that have a diagnosed or undiagnosed mental health issue. Mortality gap essentially refers to the difference in anticipated lifespan between those with and those without mental health concerns. And the literature would suggest that that's anywhere between 7 and 30 years. So if you think about the upper limit of that, that's bordering on more than a third of someone's average lifespan. That's a lot of time taken away.
Yeah, it's quite stark and alarming, and again, under-recognised. I think it's something that certainly I haven't come across too much until you really put the effort to kind of look into it. And one of the really stark findings to me as well was that this isn't just in low-income countries, but this is in places like Australia, Scandinavia, the United Kingdom as well.
Yeah, this is a global issue. This is not confined to, as you say, low and middle income countries, which we would think poverty, poor nutrition, civil conflict, all of those kinds of things that might impact mortality rates. This is directly associated with having a mental illness of some sort, and there's a whole range of potential things that influence that, independent of socioeconomic status, for example.
Yeah, and let's dive into some of that, Rob, as to why this may be. So one of my assumptions when I first came across this, which I know now not to be true, is that it's a high rate of suicide that would be causing this, particularly people with severe mental illness, but that's not the case. So yeah, what are some of those factors that really driving this 7 to 30 year mortality gap?
And you're exactly right. The common perception is that it's suicide, and certainly that accounts for a small percentage. But the two main contributors are poor physical health associated with side effects from psychotropic medications. So lots of antipsychotics, for example, will result in significant weight gain in individuals when they commence those medications. Elevated cholesterol leading to the development of what we call metabolic syndrome, so a cluster of risk factors for cardiovascular disease.
Right.
And the other major contributor is just poor health behaviours. So low levels of physical activity, nutritional inadequacies, poor sleep, those kinds of things that when you combine that potentially with the medications, really do disrupt someone's well-being and contribute to that mortality gap.
So obviously it's different person to person, but these people are dying earlier, typically from preventable chronic diseases like cardiovascular disease, diabetes, obesity, high blood pressure, these conditions that are preventable with these lifestyle behaviours.
Yeah, all the same diseases that we invest so much in and worry so much about in the general population are the things that contribute to early mortality in people with mental illness. So as you say, diabetes, cardiovascular disease, respiratory disease, some forms of cancer, the risk of developing those conditions is markedly higher in people with mental illness, which is a real concern.
Yeah, so, and you alluded to this just then, Robert, in terms of some of those kind of lifestyle behaviors, the physical inactivity, which, is pretty low in the general population, but why might that be comparatively even lower in people with mental illnesses and severe mental illnesses, particularly like depression, bipolar, schizophrenia?
Yeah, but there's a couple of reasons. And you're exactly right about the low levels of physical activity in the general population. The most recent World Health Organization report would suggest that only about a third of the global population achieves sufficient physical activity for health.
Oh, wow.
So we're already on the back foot, before we start. But people with mental health concerns face a number of additional barriers. Stigma is one. So stigma in, for example, if you if you go to a commercial fitness centre and on your health screening you declare that you've got bipolar disorder, there is a chance that whoever the trainers in the gym will be either may not know how to manage that in the context of delivering exercise, or just simply may be fearful because of the way media, social media particularly, has portrayed individuals with mental health concerns. Access to facilities, financial status, their physical health. We know that people with mental health concerns have concerns about their own capacity and capability to engage safely in physical activity, simply knowing what to do. So what we would call physical health literacy. So there's a whole range of additional barriers that that people with mental health concerns will face that are not the same as those faced by those without mental health concerns.
That's really interesting, that one about the gyms and ticking that you might disclose you have a mental illness and how fitness instructors may deal with that or may not know how to deal with that. I'm actually running a study with Oscar, actually one of your colleagues, on how do personal trainers manage mental health concerns when they inevitably come up in the conversation with the client. And Oscar pointed out that personal trainers, fitness instructors often are these accidental counselors. And I was a PT. I was a PT for about 8 or 9 years and wasn't trained in mental health at the time, was just studying my psychology at the time. But inevitably that comes up in, sessions, whether it's the distress they're experiencing at work, in a relationship, or whether it's challenges with a mental illness that they're facing. So, this group of people who aren't necessarily trained to deal with that are finding themselves in these positions daily, weekly, having to manage that. So I think it's going to be a really interesting space to explore.
Yeah, look, it is. And there's absolutely. And Oscar and I have had these conversations about the accidental counsellor aspect of being a PT or being an exercise physiologist. And given that, around 1 in 3, 1 in 4 Australians at least will experience a mental health concern at some point in their life. Almost everyone is going to encounter an individual that they know, whether it be at work, in a healthcare setting, a family member who experiences some degree of mental ill health. And one of the ways I think that personal trainers can improve or upskill their knowledge and experience in that space is through things like mental health first aid training, or some of the professional development opportunities that are about now in the health and fitness sector on exercise and mental ill health. And this has really come about over the past, I want to say 5 to 10 years, where people like Oscar and Simon Rosenbaum and others have done so much in the advocacy space to break down those barriers around the stigma associated with poor mental health. And the language has really shifted. So whereas before we would talk about a depressed person or a psychotic person, we now shift the language so it's person first. So it's a person that experiences depression, or a person that experiences psychotic episodes. Because at the end of the day, it's the person. We don't talk about, we talk about people with diabetes or people with heart disease in the same way. So why would we treat mental illness any different? There's a lot that needs to be done to break down that stigma. And the things like mental health first aid go a long way to help non-mental health care professionals better understand the conditions how to communicate really well with people who experience those conditions and then apply their own craft or their own trade, for example, exercise prescription, to that population in a way that captures their imagination, captures their interest, and keeps them interested. Because one of the critical things about exercise, and we talk a lot about exercise as medicine, like medicine, it only works if you take it.
Yeah.
And so it's one thing to get someone started, but it's another thing entirely to keep them going and to help them create a degree of independence.
Yeah, love that. I mean, there's a few points in there. So it sounds like the person-centered approach and the idea that someone is more than just their mental illness, and changing that language recognizes that.
Yeah, very much so. An individual is much more than their condition. Their condition might impact their quality of life, their willingness to engage, let's say, in physical activity on a given day, and that can be fluctuating with their symptoms or their motivation. But at the end of the day, there's still a person like you, me, and everyone else that's listening to this podcast, and we need to give people the autonomy, the respect, the dignity that they deserve. The stigma is a real issue in the mental health space, and not just from the general population through lack of understanding, but even in healthcare professions.
Yeah. No, very, very important. And I think that language, just that shift in that language certainly reflects that a depressed person versus a person who happens to have depression. Yeah.
Certainly something that I know Oscar and myself as an academic and many of our colleagues use that kind of person-centered language in the teaching that we do, and try to instill in our students that if you can use that kind of language to create a good therapeutic relationship with the client, then they're more likely to engage in what you want them to do. They're more likely to answer questions that will help you develop, again, and let's say an exercise intervention that they're going to do, and more likely to provide good feedback for you to help work out how to modify that over time, more likely to stick at it, develop a level of trust, if you like.
Yeah, okay. And this, I think, relates to a term that Oscar introduced me to actually a few months ago when he came on the podcast of diagnostic overshadowing, in the way that, a healthcare practitioner might see a person with a mental illness, but also how that relates to how they see or don't see their physical health and physical illness symptoms. Yeah. Can you elucidate us a little bit as to what diagnostic shadowing is?
Yeah, so diagnostic overshadowing is essentially assuming that someone's physical health symptoms are attributable to their mental illness. So say, for example, someone with anxiety experiences chest pain. So that chest pain could be because they're having an anxiety attack, or it could be because they're having a cardiac event. Now, if that person presents at an ED, an emergency department of a hospital, and the physician on call or the attending doctor reviews their chart, reviews their history, assesses them, the literature would suggest it's highly likely that even without conducting any cardiac investigations like an ECG, that they would attribute that event to an anxiety attack, and that person would be sent home to calm down, relax, it'll all be okay. And that may be true in a large number of cases, but invariably there will be some for whom it's not, that they are truly having a cardiac event, and a failure to undertake appropriate investigations might be seen as problematic in a healthcare setting. And so it's one of the reasons why people with mental illness are less likely to go to a hospital when they're experiencing what might be cardiac events or other physical health symptoms, because of this notion of diagnostic overshadowing. And the literature here and in the UK and elsewhere shows almost irrevocably that this does occur, and occurs more when ED departments are really busy, or people have a relatively long history of presenting with physical health concerns. And so, it impacts on the accessibility to care that someone might have, and their willingness to engage with the healthcare system more broadly. None of those things are good for the person who's experiencing those symptoms. And this is why, at least in Australia, we've seen an upshift in the number of people who are calling emergency services, so calling paramedics, when they experience these physical health symptoms, because they know that, or at least their belief is, if they go to hospital, that they'll experience this phenomena of diagnostic overshadowing and receive what they deem to be appropriate healthcare. And that has impacts on the carers as well, who will see them as just being brushed aside. It's just another panic attack. You will be fine. And as I said, that may be true in some cases, but equally it may not be.
Yeah. Do you see that this happens in primary care settings like physicians or GP practices as well, where someone with a mental illness might present to their GP and be somewhat dismissed? Their physical health concerns might be somewhat dismissed and flagged as a symptom of their mental illness wrongly?
I see that less in GP settings, but I think and not to be disparaging to GPs or the current situation that healthcare services are in, and the GP clinics are in. But it is possible that it could be easily overlooked. That someone who may turn up at their GP clinic, experience some chest pain, has a brief consultation, because our experiences these days with GPs is often that consultations are relatively brief. That they may be misdiagnosed, or something might be missed, and again, this might lead to the consumer, to the person experiencing those symptoms, developing some degree of mistrust or distrust with healthcare services generally, and not seek help when in fact they need it, either for their mental health or their physical health. And given that the two do go together more often than not, that's another impact potentially on their mortality gap, or the potential for early mortality.
That sounds like missed opportunities as well for things like early intervention, early intervention of symptoms when they pop up. If they're less likely to go and see a healthcare practitioner, given that there's less trust that they'll be taken seriously or taken with that level of credibility that they should be.
Look, again, I think there's the risk that happens. But what I will say is, I think given that there's a lot more awareness around mental illness nowadays, and I will say particularly in the workplace, that there's more opportunities for people who might not otherwise engage with a healthcare professional to engage with someone else that they trust, who might convince them or support them at least in seeking further healthcare. And so I think there's other avenues by which people might secure some support, whereas again 10 years ago that may not have been the situation.
Okay, that's an important point. You mentioned something earlier, Rob, about I think lower socioeconomic status or poverty, and that relationship to less exercise and mental illness. Can you tell us a little bit about the relationship between those three, the poverty or low socioeconomic status, less exercise and mental illness? How do they all connect?
Yeah, it's an interesting one, and one I think where there is a little bit of a shift. What health practitioners and exercise providers, and I'll just globally use that term, exercise providers, are seeing both in the literature and anecdotally is that individuals that are more active, and particularly in sport, let's say, which has a socialization aspect as well as the benefits of improved physical health from being more active, are really making inroads into low SES, what we might have otherwise seen as disadvantaged, vulnerable populations. The work that, Simon Rosenbaum, one of my colleagues here, is doing, along with many others, in refugee camps, is a really good example of this, where sport is used as a tool to address depression, anxiety, post-traumatic stress in individuals residing in refugee camps in a way that overcomes that poverty barrier. It's not about socioeconomic status. It's about bringing people together for a common good, if you like. And sport just happens to be the vehicle for that because it's low cost. It's easy to implement. The greatest challenge is actually overcoming the really simple things like, where will you get a soccer ball from? Where will you get shoes from? So it's not where will you find a stadium. It's the really kind of grassroots, low level, what we would take for granted stuff that often is the greatest challenge. But you introduce a ball, and the first thing that people want to do is kick it. It's just like kids do. And so if that's an escape from their daily routine, then that can only be a good thing. And it's it's low cost. As I said, it's easy to implement. There are programs now where individuals who work in these camps are being trained, in inverted commas, to provide some of that psychosocial support through sport. And again, the evidence that's being published shows that it's working with a high level of success.
Yeah, I love that work that's being done. Again, Oscar introduced me to it. I think Simon's done a lot of work in Cox's Bazar, one of the, if not the largest, refugee camps in the world, in terms of implementing sport as a way to help people cope with the, myriad of huge mental health challenges that someone living in those conditions faces. And when I think about my own background, I'm from Sri Lanka, and in Sri Lanka we have, I think it's an average of 0.5 psychiatrists per 100,000 people, and the rate of psychologists per person as well is not much better. So it's very much not well resourced from a mental health care practitioner perspective. And when we think of the traditional treatments we might use here in Australia, like medication and therapy, there is that element of stigma. There's not the resources, and people just aren't, culturally, it's not very ingrained to be speaking to a therapist like, someone might do here in Australia, comparatively at least. So things like exercise and sport as a way to implement in these countries where the resources aren't there, the stigma of traditional therapies and treatments is still there, I think is huge benefit, and it's so fantastic to see that being done.
Yeah, and Oscar probably would have talked about the Addy Moves program in Sydney.
He actually didn't, so do you mind telling us a little bit about that?
So when you talk about the cultural issues, the Addy Moves program in Sydney is fundamentally about providing opportunities, and the Addy House is a resource facility for female refugees who come to Australia and need to be linked up with local resources, whether they be around financial support, whether they be around simply securing clothing, finding a place where they feel safe. Oscar and others have been able to introduce a physical activity program as part of that. What they found is they needed to undertake a significant amount of, I guess you would call it, cultural safety training to understand the nuances around the relevant practices so that they could work with these individuals from other countries in a way where they could develop trust and start to introduce physical activity to a cohort of people where it's not a traditional thing to do. It's certainly not a traditional thing to talk about. And so there's been great moves in that space. And so there are pockets of fabulous success around the country like that, where not only have the participants in these programs overcome great challenges, but the people who deliver these interventions are also coping with new challenges in order to do their business as usual, if you like, in terms of exercise prescription. And it just shows, I guess, the adaptability of sport and physical activity as for want of a better phrase, a therapeutic intervention for well-being. It kind of crosses all borders.
Yeah. So it sounds like with Addy moves, I'm not too familiar with the details, so correct me if I'm wrong, but that sport and exercise is almost a way in to connect people with those other services that you otherwise may not be able to get them to access, or maybe more difficult to access.
Yeah, and it works alongside these other services, if you like. So it's a standalone kind of a program, but it's integrated into the overall, I guess, philosophy of the service, as opposed to being, well, you need to go and do sport, or you need to go and participate in physical activity as part of your integration. It's really, here's an opportunity to do something that might help you. If you think it might work, here's how we can go about it.
Yeah.
And it's working very well.
Yeah, nice. I'll certainly put a link in the show notes for people who want to check out more about Addy Moves. Hello, everyone. A quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode. One particular factor I think we should cover as well is this notion of a bi-directional relationship between exercise and mental illness. So exercise, now there's an abundance of evidence, which yourself, Oscar, Simon Rosenman, who you've mentioned a couple of times, and others have done, showing that exercise can be really effective in treating some mental illnesses like depression, schizophrenia, for example. But why, in terms of bidirectional, the other way, what's the relationship between mental illness and its symptoms affecting someone's ability to engage in physical activity and exercise?
Yeah, it's a good question, and it's one that as practitioners we grapple with all of the time. So you're right, there is this bidirectional relationship between participation in physical activity and mental health concerns. in general, it's the low participation has got quite a bit to do with the barriers that individuals face.
Okay.
For example, a colleague of mine did some interviews with some people who experienced mental health concerns, and there was talk about what type of physical activity or exercise might be beneficial.
Mm-hmm.
And one of the quotes that a participant came back with, and I'll literally never forget this.
Okay.
They said, you want us to get up every day and go for a run. I can barely get out of bed. So low motivation is a real issue. If you experience quite significant depressive symptoms, your motivation to do anything is really low, including getting out of bed. So that's why things like self-care are impacted. That's why things like self-esteem are impacted, or self-efficacy. That's why they may have difficulty in holding down a job. And so physical activity is like, well, why? What's it going to do for me? So, and I can remember when I was an exercise physiologist, or practicing as an exercise physiologist some years ago, and became very interested in this link between being more active and feeling better. Because I would see clients come into my clinic who had a range of health conditions, cardiovascular disease, diabetes, occupational injuries, those kinds of things.
Yeah.
And often they would not get better in the traditional sense. So their range of motion might not improve, their strength might not improve, their clinical markers of the condition might not improve, but invariably they would say they felt better.
Mm-hmm.
And I thought, that's really weird. How is that happening? So, again, just through talking with people, it became really quite obvious that physical activity was something that they found that they could do, that they had the capacity to do, they had the capability to do, even though they couldn't do some other things. So even though they couldn't necessarily return to work in the same capacity that they may have done, or even though for someone who had diabetes, their HbA1c, so a marker of long-term blood glucose control, may not have improved in the same way that their endocrinologist or doctor wanted it to. They felt better. They felt more capable. Their self-efficacy, their sense of self-worth improved. And so they were happier. And so even though someone's clinical symptoms may or may not improve, the fact that they're feeling better is something that you can capitalize on. And if you couple that with giving that person a sense of autonomy over what they do, so giving them choice. So rather than me saying, here's the exercise program you must do to get better based on some clinical guidelines, rather inviting them to say, if you were to pursue some kind of physical activity, what do you think you might enjoy? What do you think you might do? What have you got access to? What have you done before that has helped make you feel better? And leveraging off that information, it gives the individual a sense of power, a sense of autonomy, and a sense of self-responsibility over what they actually do. And in my experience, if you ask individuals the right questions often enough, they will tell you what they'll do. So they write their own program essentially.
Wow.
And they're more likely to do it because it's theirs. Whereas if I go to the guidelines and say an individual with depression should do some aerobic exercise 3 to 5 days a week of around 30 minutes of moderate intensity, that's all true. But if someone's struggling to get out of bed, or they experience agoraphobia and won't leave their house, how are they going to do that? And so I would give them that information, and in their head they're thinking, nah, that's not going to happen.
Yeah.
Whereas if I ask them what they might see themselves doing, all of a sudden the power's in their court. And again, in my experience, in people who have what I would call exercise avoidance, and not just individuals with mental health concerns, but individuals who experience chronic pain conditions, who may have tried exercise as a therapeutic intervention before but not succeeded, that approach of giving the power to the end user, engaging the consumer in their own health-based solutions is really, really effective. And I just kind of guide the conversation and ask the right questions. And over time, you will develop trust with individuals and they'll write their own program. And so it addresses this bi-directional issue.
Yes.
Because if you think about the experiences that someone with a mental health concern might have over the course of trying to manage their condition, every time they go to their doctor, every time they go to their psychologist, their psychiatrist, their OT, their social worker, they're having to retell their story. And that gets a bit frustrating for consumers. Whereas I might be, as an exercise practitioner, very concerned about their story and what happened to them to get them into their current scenario, but I'm more focused on them working together with me, but them leading to some extent the conversation to come up with a solution that if they feel exercise or physical activity might be beneficial for them, they know more about their own health and their own experience and their situation than I will ever know. So who's best placed to provide the exercise program? Them or me?
Yeah. I love it. This shared decision-making approach and acknowledging that they're the expert in their lives.
And you know, in recovery-oriented mental health care, we talk a lot about person-centered or consumer-focused, autonomy-driven kinds of approaches, or this notion of them being the expert by experience. And so I give them that opportunity.
Yeah.
Because they are really, and I even tell my students in exercise science, you'll learn more from clients than textbooks if you ask the right questions.
Yeah, I love that. Yeah. It's really interesting, this approach to exercise where you're allowing them to lead the way, because I think it stands in contrast to some corners that still exist that are more reminiscent of the biomedical model, where even in psychology there's still elements of a manualized therapy. Session 1 you do this, session 2 you do this, and this is the way, no matter who it is, you prescribe in this instance, and very little say comes from the consumer, the patient, the client themselves. Whereas the evidence, like you're alluding to, shows really that with exercise, what you want is adherence, coming back to what we discussed earlier in the conversation. And to gain adherence, the best way is to allow them to lead the conversation, to do what's affectively pleasing or feels good. And that can be many different things: yoga, walking, running. Doesn't need to be high intensity exercise all the time to unlock those depressive or antidepressive benefits.
Yeah. And there's quite a bit of research in this notion. You talked about affect. There's quite a bit of research in this notion of affect-regulated exercise. So having people exercise at a level that makes them feel good. And we can quantify that. There's a scale of
feeling scale.
Affect. Yeah, the feeling scale. Hardy and Rajewski feeling scale. And I've used that quite a lot clinically, where we know that if people exercise at a level of +3 on the scale, which translates to feeling good, then even a single exercise bout of 20 to 30 minutes at an affective rating of +3 is associated with greater adherence at both 6 and 12 months. So I can't feel that for the individual, but they can.
Yeah.
So if that means that during the exercise session, they need to moderate the power output they have on the bike or the speed that they walk at or the weight that they lift, that's fine. But if you monitor that affective valence and they have a good experience, naturally they're more likely to come back and want more of that good experience. It's human nature. Whereas in contrast, we have a natural tendency to avoid unpleasant things. And so if, for example, a high-intensity exercise session makes someone feel nauseous and extremely unwell, or they don't enjoy it, why would they go back to do more of that? And so using this notion of how you feel as opposed to how hard you work is sometimes overcomes the performance anxiety associated with exercise prescription. So I want you to work at a heart rate of 140 beats per minute. So they worry about their heart rate and they're not focused on how they feel. So you're introducing potentially an anxiety-producing variable or component. Whereas if you let them just have fun, if you let them enjoy the experience, they're more likely to want to come back. And it just so happens that, at least in healthy individuals, that +3 rating on the feeling scale is closely correlated to what we would physiologically call moderate intensity exercise.
Right.
So by default, they're actually exercising at the right level of intensity.
Yeah, no, love it. I'm having Professor Ryan Rhodes on the podcast, in a few weeks because I think this is such an important area to look into, and for practitioners, anyone who is implementing exercise-based interventions to understand.
And the other person who's spent a lot of time talking about this notion of affect regulation and affect in exercise, and you've probably heard this name, is Paddy Ekakakis, who's now in the US, and he's long been an advocate of monitoring affect and affective responses to exercise. Clinically, I've found that to be really useful, and from a research perspective, I've found that to be really useful. So one of the studies I published some years ago, we looked at the association between this affective valence, the good feeling scale, if you like, and rating of perceived exertion, which is just a subjective measure of exercise intensity. And we did this study in a group of inpatient mental health consumers. They were doing a self-selected exercise program. And what we found when we looked at the group as a whole is that for some people, the harder they worked, the better they felt. But for other people, the harder they worked, the worse they felt. When we separated them out based on diagnostic criteria, so we ended up with a group of people with bipolar disorder, a group of people with psychotic conditions, and with anxiety-related conditions, and a group of people with depressive conditions. At least for those with depression, the harder they worked, the worse they felt.
Right.
And so for the others, the results were kind of mixed, but there was quite a strong relationship, or negative relationship, between the difficulty of the exercise, the level of exertion, and the feeling scale. And so I think that's useful to show that whilst there's individual differences and differences between diagnostic groups, at least for people with depression, getting them to work too hard doesn't make them feel very good and may have impact on their short and long-term adherence to an exercise program.
And I think this whole notion really ties into what you alluded to earlier about exercise as medicine being a little problematic, because I know when I think of medicine, I think of, oh, well, I have to take it, it's going to taste disgusting, or you just do it for function.
And you have to have a specific dose, and you have to do it at a particular time.
Yes, you don't get to choose and have a fun medicine.
And we're conditioned, I guess, that if we're unwell, we go to our doctor or we go to our specialist and they prescribe us something and we take that and ultimately we get better. Rightly or wrongly, and I know, some of my colleagues will disagree with me. I don't think exercise is altogether like that. And I don't think it's a good message to always prescribe exercise in that way, because it takes away the autonomy. It takes away the choice from the individual. And, we know that there are an awful lot of prescriptions that are provided by GPs that don't get filled. In the same way that there are an awful lot of exercise prescriptions that don't get started.
Yeah.
And so we need to, I think there's opportunity to do better in the way we engage with our consumers or with our clients generally in the delivery and development of exercise, physical activity interventions for them.
Yeah, no, really important. And I think we could talk for hours on this. And one area I really want to dive into with you is the role of AEPs, or Accredited Exercise Physiologists. So I am not an AEP, and most people listening won't be an AEP. So can you talk to us a little bit about what an AEP is, particularly for those who aren't Australian as well? Because I understand it's quite a specific role here in Australia, and the role that they might play in exercise for mental health, mental illnesses.
Love to. And thanks for the opportunity for doing that. So AEPs are university-trained health professionals with specialist training in providing exercise and physical activity interventions for people with or at risk of chronic or complex health conditions. Now, I know that sounds very much like a textbook definition, but I had a couple of years ago a very similar question from a visiting professor at our university whose discipline wasn't exercise science, but his daughter was studying exercise physiology.
Okay.
And he was asking her, so, what is it that you'll do when you finish your degree that I'm paying for?
Nice. Fair enough.
and she was unable to articulate to her father what it is that she would be doing.
Yep.
So very broadly, we go to university for 4 to 5 years. Typically, people would do a 3-year undergraduate exercise science degree and then a 18-month to 2-year master's degree, so master's by coursework, where there's a lot of clinical placement. So you're out there in the community or in hospital settings working with people with chronic or complex health conditions. That could be anything from chronic low back pain, diabetes, heart disease, neurological conditions like cerebral palsy or stroke rehabilitation, or it could be, and there's much greater interest now, again, in the past sort of 5 to 10 years, in the mental health space.
Okay.
Where AEPs differ from, let's say, physiotherapists is that we deal, and I've been an AEP for 20 years now, and spent 10 years, just over 10 years, in my own private practice as a clinician. Where we differ often is physios, and this was certainly the way that my business model was set up, for musculoskeletal conditions at least, things like back pain, neck pain, knee injuries, post-surgical interventions, those kinds of things. The physios would typically look after the acute phase, so immediately post-surgery or post-injury. And then when it came time for work hardening or return to work programs or physical conditioning to return to work or return to sport, that was handed over to me as the exercise physiologist.
Okay.
So we work alongside other health professionals, and embedding exercise physiologists as part of multidisciplinary teams, I think, is a really smart move for health services, because it reduces the burden and expectation on, let's say, physios or even OTs or other professions, so they can focus very much on what they do, but when it's appropriate, refer on to AEPs in the same way that for me as an AEP, if there was a particular condition or a particular client that I saw where I thought they needed specialist intervention from someone else before I could do my work, then I would refer them on to someone else. In the last, again, 5 to 10 years or so, we've seen a lot more opportunities for and a lot more exercise physiologists working in mental health settings. So in hospital settings, in both public and private settings, in forensic mental health care units, working alongside psychiatrists, working alongside psychologists, social workers, mental health OTs, mental health nurses, but there's still an awful long way to go to have it embedded as part of routine care.
Yes.
So whilst, and I'm going to be biased and say we have an awful lot to offer mental health care, we're still often overlooked as a useful resource.
What might that look like in terms of an exercise physiologist being embedded in mental health care? So let's just paint a bit of a picture here. Most people with mental health concern will first, here in Australia at least, will first see their GP, their physician, and if needed, get a referral to then see a psychologist, which they can usually do at a subsidised rate under the national Medicare system. Yep. Where would an exercise physiologist fit in ideally into that kind of puzzle?
Yep. So I think there's a lot of opportunities, but the two main opportunities, one would be part of that enhanced primary care referral scheme. So GPs can refer to a number of other allied health professionals under a Medicare subsidised scheme, where an exercise physiologist could consult with a mental health consumer about developing an exercise intervention. The number of referral contacts is really quite limited, so it's 5 contacts across a year with at least 2 healthcare providers being involved. So whilst there is some opportunity, that's scope for that in terms of ongoing care, unless a person is able to self-fund their visits, is pretty limited. The other opportunity would be as part of a multidisciplinary team in a hospital setting. So let's say, for example, someone was hospitalised, so they're an inpatient in a mental health care unit for a period of time. We know that physical health generally is not well done in inpatient mental health care units. Right. Myself and a number of other people have consistently shown that even simple things like waist measurement are not routinely done as part of physical health care oversight, managing physical health care. Yet we know that that's a contributor to the mortality gap. So if in that inpatient setting there was an exercise physiologist, even if there wasn't a gym there, but their role was to oversee some physical health care, take some routine physical health measures. It might be around cardiorespiratory fitness, might be around waist circumference, it might be around screening for physical activity opportunities for that person. It might be running very simple physical activity interventions that don't require any equipment, like walking groups, like calisthenic type activities, like exercise programs using resistance bands as opposed to using weights, which might cost more, might pose additional risks, all of those things that people have. So they're probably two opportunities, I think, that become important. At the moment, the referral scheme doesn't really offer the opportunity for psychologists or psychiatrists to refer to exercise physiologists under a rebatable scheme unless the consumer has private health insurance and their health insurer covers exercise physiology services.
Right. Okay.
Two opportunities I think go potentially underutilised. The NDIS, National Disability Insurance Scheme, is one. The problem I have, and I guess I'm going on record saying this, is that often the funding for an individual is managed by someone who may be acting in the best interest of the consumer, but not fully aware of the specific needs of the individual. And so I think there's opportunities for fund managers or client managers to work more closely with a broader range of health professionals. The other one is what's called the Better Access Scheme, which GPs can refer clients to or consumers to, but there's a limited number of health professionals that can access funding under Better Access. So I think that's limited to OTs, psychologists, social workers, maybe one other. I can't remember who that is. But exercise physiologists are not included in that group of health professionals. There's advocacy in that space, and while a number of mental health OTs would perhaps argue that we're well equipped to do that, if EPs, exercise physiologists, were involved, then EPs could be focused on the great work they do in the mental health mental health OT space, whereas EPs could then be better utilised to help with physical activity interventions, working alongside the other clinicians.
Yeah, it's really interesting to see that some of the peak bodies, I know you have a lot to do with ESSA, the Exercise and Sports Science Association for Australia, but in conjunction with Australian Psychological Society. So the peak body for psychologists here in Australia have called for more of this integration, but it seems to be very slowly happening.
Yeah, we often liken it to research translation. Some people argue it takes up to 17 years for research findings to be translated to practice. We're well over that time period in terms of embedding physical activity and exercise physiologists as part of routine mental health care. So, despite really good pockets of success around the country, and probably one of the most well-known, most successful programs that people model in this integration off is the Bondi Clinic in Sydney. There's still a long way to go in terms of it being routine. That, if you're either admitted to hospital or you see a psychological service, that an exercise physiologist is part of that. We're a long way off that yet, despite the best efforts of many people, many of my colleagues and many others around the country and around the world.
Yeah, it seems like certainly a watch this space, and hopefully there is a lot of progress, because this is obviously, given everything we've talked about, a really important change that needs to occur. And look, we could go for hours more, Rob, but I want to respect your time. So, thank you for coming on, for sharing what is really some important, vital, and, like we said at the start, information that is not talked about enough. I certainly hope and trust that it will land on the right ears, people listening, particularly psychology students who hopefully have a greater awareness of this. So really appreciate your time.
I appreciate it. In my career, what's been really great to see is how far it's come in the last 5 to 10 years. And a few of us were discussing this at the ESSA conference recently about, how many more EPs are working in the mental health space and how less stigmatized it's become. But there's still a long way to go. So as you say, I hope listeners kind of think a little bit more about how they can integrate physical activity as part of the care they provide for individuals with mental health concerns, not to address just the mental health aspect of someone's overall well-being, but their physical health care as well.
Yeah. Fantastic, Rob. Fantastic. All right. Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental well-being. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.